Welcome to World Schema Therapy Day and this Group Schema Therapy track. Thank you ever so much to Diana for organising this. This presentation describes group schema therapy in a forensic inpatient setting. My name's Louise Sainsbury and I'm a consultant clinical and forensic psychologist and joint lead psychologist in the Men's Personality Disorder Service at Rampton Hospital in the UK. I'm going to outline the forensic service and the rationale for the use of group schema therapy in its treatment pathway. I'm going to talk through the group schema model we use, the dynamic risk factors this focuses on, the lessons we've learned, the extras it's brought, and I'm going to finish with feedback from the patients. The men in this service have typically experienced severe attachment insecurity, abandonment, abuses, neglect, typically within discrimination and poverty in the wider culture. The majority of patients have been taken into the care of child social services and they've had many placement breakdowns as well as further abuses. Their placement breakdowns have often been attributed to their poor behaviour. The severity of what has happened to them in their childhoods is considered a causal factor in the development of the severe and complex difficulties that receive a diagnosis of personality disorder, as well as other multiple mental health disorders. It's further considered causal in the development of their violent offending. Typically, the men are assessed as at high risk of violent reoffending on admission and often present as high risk to themselves. Patients are referred from prisons and medium secure units across the UK and have frequently been assessed as having failed standard programmes, typically CBT, skills-based, or to have engaged but not to have made sufficient risk reduction work and are considered to need specialist intervention over a longer duration. Some of the patients have not been able to attend groups previously due to the severity of their mistrust and their risk behaviours to others. The service provides assessment, formulation and treatment over an average length of stay of 7 years. This reflects the severity and complexity of their risks, mental health and treatment needs. The psychological treatment pathway has been evolving over the last 25 years as psychological therapies for personality disorder have been developing. The pathway began integrating DBT, schema therapy, and offending programs within a phased approach that emphasised the need to work with difficulties in engaging in treatment and motivation. The pathway has continued to incorporate ongoing developments within therapies, including trauma-focused therapies, body-focused approaches, working with the threat system, and from the forensic field, the development of the Good Lives model. The first phase focuses on building secure therapeutic relationships that provide consistent experience of safety, containment, attunement, and co-regulation to begin to develop trust and to reduce presenting risk behaviours. This is alongside and supports the collaborative assessment and initial formulation of their mental health, offending, and treatment needs. The second phase focuses on exploration, processing, and change. This typically involves working with childhood traumas, the impact on adult patterns of relating and coping, and further developing their ability to tolerate feelings of shame and mistrust arising from what was done to them and from what they did to others. The final phase focuses directly on their offences, detailing their offence cycles, developing risk management plans, incorporating their strengths and protective factors, building on the changes they have been making, and planning their future for a good life. Individual schema therapy was first incorporated into the treatment pathway to meet that need for providing formulation and a treatment approach for the impact of childhood traumas on personality and offending. It is well established that there is a strong association between the experience of childhood traumas, adverse experiences, and the development of mental health difficulties and offending. Schema therapy is formulation of the self as a multiplicity of parts or modes that developed as survival adaptations to what happened to them during childhood provides a framework for formulating those links between childhood trauma, mental health, and offending. Schema formulations have been significantly helpful in supporting staff to understand patients' difficult behaviours and to guide providing effective responding care and treatment. The schema therapy model that schemas and schema modes develop as survival adaptations to primary human needs, for example, safety, connection, emotional expression, and nurturance, were not sufficiently met. This is the same theory of human motivation that the Good Lives model is based on to formulate sexual and violent offending. This provides further theoretical validity in the use of schema therapy in the treatment of violence. Alongside this, there have now been a number of RCTs, initially in non-forensic populations, including for individual and group schema therapy, that have shown its effectiveness. More recently, Bernstein and colleagues have shown on a multi-site RCT the effectiveness of individual schema therapy for the treatment of violence for men with personality disorder, including antisocial and psychopathy. Within the men's personality disorder service, individual schema therapy was proving helpful in developing patients' understanding of themselves, including their offending. Patients were describing the mode model as particularly helpful in managing their feelings of shame that had previously been a significant barrier to their engagement in therapies. The majority of patients have experienced traumatic family dynamics, for example, being dominated and threatened with how they should be and who they should be, being the only sibling who was abused and excluded. As the majority of patients have experienced traumatic family dynamics, including being dominated and threatened with how they should be and who they should be, and being the only sibling who was abused and excluded, and then bullied in school, they often have significant difficulties in relating to individuals, in particular within groups. This pattern of relating in groups is typically repeated in the ward environment and related to risk towards staff and patients. This highlighted the potential benefits of group schema therapy. In the early 2000s, Dr. Kerry Beckley, clinical psychologist, and Dr. Neil Gordon, nurse consultant and psychotherapist, developed a 4-phase group version of schema therapy, which incorporated the work of Yalom on primary therapeutic factors such as universality, cohesiveness or belonging, and corrective recapitulation of primary family. These therapeutic factors are consistent with the primary human needs and limited reparenting within schema therapy, or as Dr. Beckley coined at the time, limited refamilying. The schema group was initially developed to be consistent with phase 2 of the treatment pathway, focused on exploration, healing, and change. This included developing understanding and insight into the schemas and modes that contributed to the development of their violence. It specifically did not look at the details of their offending. In part, this reflected the need to develop healthy adult mode ability to tolerate self-reflection in a group without becoming overwhelmed by shame and mistrust, and triggering modes to the extent that they shut down and disengaged. This is further to prevent re-traumatization or vicarious traumatization and other iatrogenic effects, and is consistent with similar changes in offending programs. The selection and preparation for group schema therapy is predominantly undertaken by the individual schema therapist in consultation with patients, multidisciplinary teams, and the group schema therapists. As you can see on the slide, Module 1 begins with schema education and awareness, building into Module 2 and the self-formulation. From this, Module 3 focuses on schema healing and change, and Module 4 brings it all together to look to the future and to look at the ending of the group. The group typically runs for about 18 months, dependent on the number of the patients and the strengths of their schemas and modes. Individual schema is started first, and the patient starts group schema therapy when they have sufficient healthy adult to tolerate the group, although there's some adjustment in terms of when groups are starting. The combination of individual and group schema therapy has been found to prepare patients and support them through the group, in particular with generalising from their progress within the individual sessions into the group context. Module 1 focuses on the education of the schema model and what group schema therapy involves. This is to form group safety and connection. In the first session, group members' hopes and fears are drawn out, and these are used to collaboratively agree how they want the group to be. This is a way of doing group rules that focuses on the interpersonal aspects. Developing awareness of needs, schemas, and modes involves the group members disclosing and sharing vulnerability to the group. This is often triggering for schema and schema mode behaviour, which is actually the purpose of Module 1, so that the group members, in a structured and contained manner, can experience beginning to disclose aspects of themselves, experience vulnerability, and this being responded to with safety, acceptance, and limited reparenting and refamilying in a group. This is challenging given the strength of schema mode behaviours. For example, the avoidant protector mode, shutting down and withdrawing, subtly or not so subtly, moving themselves at a distance from the group. The over-controller modes, asking questions, demanding certain answers, and the overcompensator modes, reacting angrily to the content or to certain actions or looks from people in the group. These mode reactions often trigger other group members' mode reactions, resulting in schema chemistry. Group therapists containing mode activation through a combination of limited reparenting, limit setting, and empathic confrontation is crucial in developing group safety, trust, and cohesiveness. And this is a large part of providing corrective emotional experiences of groups. In this module, this is carried out by the group therapists. As group members develop their healthy adult modes, they increasingly provide containment and feedback. Education on the primary needs in childhood, for example, for safety, acceptance, emotional nurturance, develops group members' understanding of what primary needs are and their experiences of to what extent their primary needs were met or not. Each schema and mode are introduced using Klobb's model of experiential learning, in which an experiential exercise that is designed to trigger a schema or a mode, whilst keeping group members and the group in a window of tolerance, so that they can reflect on their experience in the exercise and the relevance to themselves and their development of their offending. Examples are drawn from day-to-day life on the ward and developed into scenarios that are adapted and sometimes exaggerated to work with the particular group members and their mix of schemas and modes. These are introduced in the experiential form of imagery or role-play exercises in either whole group or subgroup settings. For example, being informed that the ward is having a change of ward manager and the rumour is that the new ward manager is going to be bringing in much stricter ward rules. The emotions, physiology, cognitive and behavioural reactions are shared and reflected on as a whole group. The group is then asked what the schema mode is that we were aiming to trigger. And as a group, we note the variety of schemas or modes that the group members experienced. The relevance of schemas and modes being focused on is considered for each group member, and present-day triggers, childhood origins, and the relevant needs are discussed. Despite best efforts, these exercises can trigger stronger schema mode reactions, and it's through the limited reparenting, limit setting, and empathic confrontation of the individual and meeting primary needs for safety and protection of the whole group that is crucial to the bonding and safety of the group. Within this, maintaining a focus on all group members and emphasising that all are accepted here and that schema mode reactions, especially overcompensation modes, will and can be contained. This is providing that limited refamilying that is central to group schema therapy, healing and change. Mode activation further provides the moment to undertake what Joan Farrell and Ida Shaw in their group schema therapy model call opportunity work. This is where the mode reactions of an individual are therapeutically worked with while the session content is put on hold. The ways in which these are worked with is guided by the strength of the healthy adult mode in that session. For example, a group member triggered into bully attack and who responds well to limit setting may in Module 1 be invited to work on identifying what schemas and child and critic modes and needs the bully attack are linked to, and to experience the limited reparenting from the therapist, and combined with inviting group members to share similar experiences and support. In Module 3, there would likely be more focus on rescripting and their healthy adult undertaking the healing and change with involvement from the group. Module 1 predominantly works with dynamic risk factors of emotional, cognitive, behavioural instability, traumatic experiences, developing insight into self and treatment needs, and working with personal support, stress and coping, and of course, personality disorder. In Module 2, group members are asked to draw together a lifeline or an autobiography and a schema mode formulation, and then present this to the group. The process of presenting their self-formulation is structured and prepared for in the group sessions as well as the individual. There is a focus on intentional limit setting in which group members are asked and supported to both disclose more than their coping modes are comfortable with and set an upper limit on what they'll disclose, which their healthy adult can contain with support from the group. The individual sessions provide support with the content and identifying the limit setting, as well as planning safety nets, including sharing with group therapists when to step in and stop them if they're starting to disclose past their limit. Preparation for presenting their self-formulation includes sharing hopes and fears and identifying how the group can meet the primary needs for safety, freedom from emotional expression, and acceptance. This highlights the process of experiencing effective self-control through making intentional and deliberate choices, using support, and reducing impulsivity, which reflect frequently significant dynamic risk factors for offending. The process of listening to group members' presentations is prepared for, including that there is likely to be significant shared experiences that could be mode triggering, and plans for managing possible reactions are made with a focus on not impacting on the group member presenting their formulation. Asking questions and giving feedback is structured with group members being asked to commit to everyone giving feedback and no one staying silent. This is to reduce the likely potential for triggering mistrust, abuse, defectiveness, and other primary schemas. The group therapists present their limited life history and schema mode formulation focused on their careers. This is to model the process, including limit setting of disclosures and responses to questions. It provides the group with experiences of how the group respond to the formulations and disclosures of vulnerability and how the group therapists manage that process. This further builds trust in the safety of the group therapists and bonds the group. Group therapists' presentations are informed by guidance from a range of approaches to self-disclosure within therapy. For example, self-involving self-disclosure in DBT and the use of disclosure within interpersonal therapy by authors such as Yalom. Within this, it's critical to take into account the potential to be used in a harmful manner against the group therapists, for example, by the bully attack mode. The same process of planning and limit setting is emphasised in the group therapist's preparation for undertaking their formulations. This process has consistently resulted in patients responding with empathy and respect and expressing appreciation and gratitude for the trust placed in them, combined with recognition that they had inaccurate assumptions about the group therapists, resulting in increasing security in the therapeutic relationships, as well as somewhat reduced anxieties about presenting their own lifelines. This process has consistently resulted in increased vulnerability being shown and valued by the group members, with increased self-awareness and self-coherence and a shared understanding of each other. As one group member reflected, seeing a fellow group member disclose that they had been sexually abused in childhood and that the rest of the group members did not look at him any differently allowed him to disclose his own sexual abuse. There is typically a corresponding reduction in schema mode activation and schema mode chemistry between group members, and a strengthening of healthy adult qualities and the overall bond of the group. This module works on the dynamic risk factors of emotional, cognitive, and behavioural instability, traumatic experiences, relationships, further builds on insight into self, treatment needs, and risks, including violent thoughts, other antisocial behaviours, and developing further responses to stress, being able to cope more effectively, access personal support, and increases treatment compliance. Following the formulations, Module 3 focuses on schema healing and change. Kerry Beckley and Neil Gordon structured this module using the 3 change strategies of cognitive, emotional, and behavioural approaches. Group members are asked to focus on their strongest 3 maladaptive coping modes across the 3 change strategies. Working on their maladaptive coping modes involves working with the other related modes, including their child modes, their critic modes, and strengthening their healthy adult modes. This structure involves the group therapists having to hold in mind the key modes of each group member and be alert to other mode reactions occurring in the group. In our experience, whilst there is some variability in the modes or flavours of modes, there is significant consistency reflecting the core of the mode model, with all patients identifying critic, avoidant detached protector, and bully attack modes or other overcompensator modes in which they've offended. This combination, in response to vulnerable and angry child modes, are frequently in the mode sequencing of their offending. In this module, we start with cognitive strategies, as these tend to be somewhat less triggering than emotion-focused ones. This includes schema diary cards, pros and cons and decisional balances, and identifying and practicing healthy adult. The emotion-focused experiential exercises build on the cognitive work and include continuing to use safe place imagery developed in Module 1, imagery rescripting, and emotion-focused chair work. The aims within this to contain critic and maladaptive coping modes and meet the needs of the vulnerable and angry child modes through strengthening their healthy adult mode abilities to do this. Initially, this is led by group therapists, then increasingly supported by group members, reflecting their increased trust and bond with each other. For example, within the cognitive work, undertaking a pros and cons for both the critic and the healthy adult mode is then used within chair work to give voice to both the critic and the healthy adult, with a focus on emotionally understanding and containing the critic through strengthening the healthy adult. There is considerable focus on the critic mode and the offending modes, with bully attack being the most frequent, and the functioning typically being a form of retaliation against past harms and expected future threats. The bully attack mode typically further aims to give the message to everyone else that they are not weak and cannot be harmed by others. Much of the imagery rescripting undertaken in this section focuses on linking from bully attack triggers in the present to experiences of harm in childhood and having the whole group rescript and support the vulnerable child. The emotion-focused approaches typically culminate in group members writing a no-send letter to an adult who caused them significant harm, usually a parent, and writing this from their healthy adult mode, in which they express the harm that they did to them in childhood and the impact this has had on them in adulthood and what they needed. Their healthy adult mode is supported to listen to and effectively speak for their vulnerable and angry child modes. This frequently brings up a range of difficult and often apparently contradictory emotions, frequently including about who holds responsibility for harm, blame, rejection, etc. This is often where the critic mode is particularly vocal, and experiential, emotion-focused strategies are used here to support the healthy adult in listening to the vulnerable child whilst quietening the critic. The group members read their no-send letters to the group. By this point, the group members are generally leading on taking care of each other's vulnerable and angry child modes and supporting the healthy adult modes. The behavioural change approaches focus on strengthening healthy adult leadership and containment of modes. A significant amount of this module is focused on each group member identifying a triggering scenario for their strongest schema mode, which is usually their offending mode. The scenarios are scripted, including the responses from each of their modes and the sequence in which these modes are being triggered. For example, vulnerable child mode is triggered in reaction to perceived humiliation. Avoidant protector initially takes over, and the critic reacts to this with messages to not be weak, pathetic, and to stand up for yourself, driving the bully attack or the conning manipulator or other overcompensation offending modes to take charge and retaliate. This scenario is then role-played by the whole group. The group member whose scenario it is role-plays their healthy adult, and the group as a whole, with input from the group therapists, identify which other modes it would be helpful for other group members to role-play. By this point in the group, they are usually very good at knowing which mode which patients would really benefit from role-playing. For example, the patients who really struggle to give voice to their angry child role-play the angry child. Those who have strong overcompensating modes are invited to play avoidant modes. One group therapist takes charge in directing the role play, with the primary focus to keep it at an effective level of difficulty for the group member to strengthen their healthy adult. The experiential exercises in Module 3, as well as throughout the group, are heavily drawn from the work of Joan Farrell and Ida Shaw in their seminal books on group schema therapy. This module continues working on dynamic risk factors listed above, with increasing emphasis on strengthening healthy adult mode qualities to proactively manage these areas of risk. In particular, by this module, group members are increasingly supporting each other by encouraging desistance from offending-related behaviours, whilst valuing the group members and wanting them to have a good life. This reflects significant development in peer relationships, particularly around issues of difficulty in how loyalty is perceived, and links to the obvious risk factors of antisocial peers. Module 4 focuses on the future and the ending of the group. It begins with identifying the changes they have been making and what they need to continue after the group has finished. They review their original formulation and present a reformulation in which they reflect on the changes in their schemas and schema modes and the developments of their healthy adult. Visual representations are used, such as schema mode pie charts, to highlight the ongoing presence of modes, but the changes in their strength. They are asked to consider what's helped them make these changes and what they will need in the future to continue to strengthen the healthy adult and build their good lives. The reformulation further provides them with an opportunity to make disclosures that they have not felt able to make at the formulation phase. They are asked to share their formulations with their nursing and multidisciplinary teams and to ask for feedback as part of generalising and continuing to develop their progress. The second part focuses on the ending of the group. For many of the group members, this is their first experience of being accepted and effective in maintaining healthy adult group relationships in which they have shared vulnerability, been heard, supported, and where they feel confident in supporting, including limit setting, with others. The focus on the ending of the group is to give voice to their experiences and feelings about this and the ending of the group. There is a further focus on each group member giving feedback to each other group member on what they have valued in them, how far they have come, and what they hope for their future. Lastly, all group members are asked to write an ending letter to the group, which is read out in the final session. These ending letters typically demonstrate the development of their healthy adult mode, particularly in expressing connection and value of each other. So, lessons learned. Over the course of running these groups, we've learned lessons, some of which we've had to learn repeatedly due to the challenge of working with the complexity of group members with multiple interacting schemas and coping modes and managing the risks that can arise from heightened primary schemas and modes being triggered. This highlights the importance of the combination of structure and experiential freedom in which it is safe to be spontaneous and play in finding healing and developing change. Due to this complexity and managing risk, we run groups, depending on the number of patients and the risk presentations, with a minimum of between 2 and 4 therapists. And in this team, there will usually be at least 2 experienced schema group therapists. This reflects the challenge of tolerating and containing coping modes, both the patients and the therapists, with balancing individual and group needs and maintaining group schema therapy and not slipping into individual therapy being watched by a group. Having experienced therapists is vital, particularly during Module 1 when group members' schema coping modes, particularly detached protector, paranoid overcontroller, and overcompensation modes are active. These can frequently trigger the group therapist's own schemas and modes at a time when more limit setting and empathic confrontation is required. And these are generally considered the hardest parts of group schema therapy. This is why prioritizing preparation and group reflection time, along with supervision with a focus on therapist co-working, is essential in supporting, resourcing, and developing group schema therapists to provide effective group schema therapy. As has been highlighted, hopefully throughout this presentation, group schema therapy brings some significant extras to the treatment pathway. This is principally an extended experiential focused approach to working with complex and severe presentations, personality disorders, and offending risks that occur predominantly within group relationships. Group schema therapy provides the corrective experiences or limited refamilying through the repeated experiences of being in a group that more often listens to, thinks about, supports, in which they are accepted and their primary needs are recognised and attended to. Hearing the same themes and experiences of other group members reduces feelings of being alone, increases feelings of connection, and contributes to the development of a more coherent sense of self. A significant extra the group brings is in the power of the group working together to provide the limited sibling or healthy adult support and ideas in developing each other's healthy adult modes. Finally, the group provides a bridge in developing and generalising their changes between the individual's schema therapy and the ward environment. This has all culminated in the effectiveness we've seen from formulating and working with dynamic risk factors in a group schema therapy setting. The increased healthy adult abilities for self-reflection and change in the majority of patients has led to the offence-focused group therapies integrating group members' schema mode formulations at the beginning of that group. The use of mode sequencing to formulate violent offending and healthy adult approaches to risk management and building future good lives has further been integrated into the offending groups. I'm going to finish with feedback we've received over the years from patients who have participated in group schema therapy. These comments are from patients who've completed the group. We have had a very low dropout rate from group schema therapy. We think in part this is because it's combined with individual schema therapy, as well as the focusing group on safety and bonding. When this has occurred, the individual has typically continued with individual schema therapy, reflected on their experiences of the group and what led to them dropping out, which has then informed subsequent treatment. As you can see from the slides, the patient's feedback highlights some of the therapeutic factors and changes they have made and the impact of these on each other, as well as the themes of safety, understanding, and being able to face difficulties and make changes. Thank you for watching this forensic group schema therapy presentation and for attending World Schema Therapy Day. Please contact me if you have any questions or for any of the references. Thank you.